Good morning, everyone, and welcome to our Friday morning Tyro multidisciplinary seminars. Welcome to our weekly program. I am Mark Erkin, and I'm coming to you live from New York. I think somebody stole that line from me later on a Saturday night here. But in any event, I am really thrilled to be able to introduce our panel this morning to continue on a topic that we've covered of late here, which is ablative techniques for thyroid disease. And we're going to talk about a very specific area of the use of radiofrequency ablation. I'm thrilled to have two experts in the field, Dr. Roberto Valcavi, who is the medical director of the Endocrine Thyroid Clinic in Reggio Emilia, which is located in Italy. He has dedicated his career to the diagnosis and treatment of thyroid disease. And during the past decade, really has focused his attention on various ablative techniques. His primary focus at this time is on the use of radiofrequency ablation, both clinically and from a research perspective. In addition to his clinical responsibilities, Dr. Valcavi has been extremely active both nationally and internationally. He founded the Italian Association of Endocrinologists that now has over 2,500 members. He is currently the president of the International Association for Thyroid Nodule Therapies. Dr. Valcavi, I want to welcome you. It's both a pleasure and an honor to have you join us for this program. We are also joined this morning by Dr. Vaninder Dhillon, who is an assistant professor of otolaryngology, head and neck surgery. She is at Johns Hopkins Medical Center. Dr. Dhillon is dual fellowship trained in both thyroid and parathyroid management, as well as laryngology. She has combined these two disciplines to establish her research interest in neurologic changes resulting from thyroid surgery and, I dare say, thyroid ablative techniques. She is therefore the ideal person to provide commentary on our topic this morning, which is geared towards the preservation of laryngeal function in RFA. And so with that, as always, I want to encourage our listeners to send in their questions. I will do my best to get to as many of those as I possibly can before the end of the hour. And so without any further ado, Roberto, I'd like you to go ahead and start. If we could just bring up your slides.
Thank you for giving me this opportunity to talk to you today. I'm going to discuss the fundamentals of recurrent laryngeal nerve protection during thyroid radiofrequency ablation. I declare I have no conflicts of interest. Some brands may appear on apparatus in this presentation which were technically impossible to remove. Before starting my presentation, I would like to briefly review the anatomy of recurrent laryngeal nerve, RLN, which is a branch of the vagus nerve. The left recurrent laryngeal nerve loops are under the aortic arch, while the right RLN loops around the right subclavian artery. Then RLN run posterior to the thyroid gland in the tracheoesophageal groove and enter the larynx at the cricothyroid joint to innervate all intrinsic laryngeal muscles, except for the cricothyroid muscle, which is innervated by the external branch of the superior laryngeal nerve. RFA proceduralists should be aware that recurrent laryngeal nerve has many anatomic variants. Most notably, among these variants is in about 40% of cases, the RLN splits into 2 or more branches prior to entering the larynx. Due to its small diameter, the RLN cannot be detected by ultrasound. In ultrasound imaging, the RLN is positioned in the so-called danger triangle or danger area, posterior and medial to the thyroid lobe. Thermal injury to RLN and inferior laryngeal nerve causes hoarseness of variable severity and phonation difficulties. Furthermore, laryngeal muscular weakness can develop, producing dysphagia and the risk of aspiration. Although many authors claim that thermal damage to RLN is reversible over time, full recovery of voice quality and laryngeal intrinsic muscle strength is very questionable. Hence, recurrent laryngeal thermal injuries during thyroid RFA should be absolutely prevented. In my talk today, I would like to present and describe the technical precautions we have adopted in RFA procedures in order to protect the danger areas against excessive eating. First, let's talk about the importance of anterior and posterior hydrodissection compared to anterolateral hydrodissection. Second, I will discuss electrode needle positioning and initial generator settings. Next, we will see why the ablation should start at the lower nodule. Following this, we will examine several sedation options. After that, we will consider the correct exposure length of electrode needle tip. And following this, we will examine several options in order to improve patient experience, mitigate pain while still permitting to precisely and carefully assess voice quality during RFA. Then I will present the use of flexible fiber optic laryngoscopy, FFL, for challenging ablations. And finally, I will discuss our ultrasound technique for standard vocal cord mobility assessment during RFA procedures. This is how we carry out anterior and posterior hydrodissections. The RFA procedure is preceded by pericapsular local anesthesia and anterior hydrodissection. An injection of 10 mL 2% lidocaine is performed under ultrasound guidance using a 25-gauge Chiba needle. Anterior hydrodissection and local anesthesia separate strap muscles and the sternocleidomastoid muscle from the nodule. For posterior hydrodissection, 20 to 30 mL 5% cold dextrose, D5W, is administered. Here you can see the needle tip posteriorly inserted. Anterior and posterior hydrodissection merge, thus separating the nodule from vital neck structures. This slide shows an alternative technique presented by Beck. In this procedure, a hydrodissection steel needle is inserted anteriorly and the fluid is injected until it hydrodissects also the posterior compartment. You can see in the left panel the ultrasound imaging. The hydrodissection needle is kept in position during RFA procedure for continuous D5W infusion. At the same time, the RFA needle is activated. This procedure could have two risks. The first would be the possibility of a voltaic arc between the two needles. They are both of steel needles. The second one could be problems in achieving and maintaining hydrodissection of the posterior compartment during the complete procedure. Although these are most used hydrodissection techniques, other modalities have been reported. We could discuss them later. An RLN injury due to cold D5W temperature could be presumed. For this reason, a few authors propose to administer D5W at room temperature or at 37 centigrades. However, most RFA proceduralists use cold 0 to 5 centigrades D5W without reporting any side effects. Cold D5W is thought to counterbalance RFA needle electrode heating. As a side effect, as a rare side effect, you should consider the possibility of perithyroid hemorrhage, which has been reported in 2 cases only. Continuous hydrodissection with a steel needle, as reported by Beck, could be challenging because the needle could be easily slide inside or out perithyroid tissues. In order to avoid the risk of a voltaic arc, a plastic catheter should be used instead of a steel needle. However, positioning a venous catheter, a plastic venous catheter in the tracheoesophageal groove can be cumbersome, and the silicone cannula can bend or kink. We had that experience. We prefer to avoid these aforementioned risks by withdrawing the hydrodissection steel needle before applying RFA electric current. In order to maintain a buffer zone between the nodule and the danger zone during ablation, injection of cold D5W may be repeated as many times as necessary. The video on the left shows a repeated posterior hydrodissection in a partially ablated nodule. This is the partial ablation and still permits the repetition of hydrodissection. After re-establishing RLN protection through repeated hydrodissection, RFA can resume until the ablation is completed, as seen in the video on the right. These techniques permit total nodule ablation, which is the ultimate goal of RFA. We proceduralists know that if the ablation is incomplete, very easily the nodule will recur. As reported in the literature, an RLN rescue hydrodissection procedure has been established in the case that dysphonia occurs during thyroid RFA. In a representative case reported by Ali Jamal, hoarseness was detected during ablation of the inferior part of the nodule. The procedure was stopped straight away, and 10 mL of cold D5W was injected into the tracheoesophageal groove. Here you can see the needle tip. Patient voice immediately returned to normal and stayed normal in the following days. This has been demonstrated in several other cases and demonstrates that injection of cold D5W mitigates thermal injury to RLN during RFA. This situation, although rare, could arise in standard RFAs. In any event, RFA proceduralists should be familiar with this rescue procedure. Let's look at how the radiofrequency needle electrode is inserted. The needle electrode is positioned in the inferior part of the nodule, adjacent to danger zone, which has been isolated and protected by hydrodissection. This is hydrodissection, which separates the nerve from the nodule. Using a standard exposed tip of 10 millimeters, the generator is initially set at a minimum value of, say, 10 to 20 watts and should stay below 30 watts and should never exceed 40. Using power settings higher than 40 watts runs the risk of boiling the liquid fraction of the cells and carbonizing tissues. As we have just stated, we do not need to reach high temperatures to obtain ablation. At 60 degrees centigrade, it takes only 1 second to coagulate cellular proteins and thus cause cell death. This is 1 second only. Therefore, the RF generator is usually set at a maximum temperature of 65-70 degrees, and impedance peaks, which indicate tissue boiling, should be avoided at all times. Looking at this standard generator display, I would like to point out some important parameters, such as impedance, which varies depending on tissue conductivity, and in this case is momentarily 114 ohms. Power, in this case 20 watts, timing of RFA, temperature of needle tip with circulating coolant. Other parameters such as tension in voltage and current in ampere are regulated automatically by the generator. Cooling the needle tip with cold saline is an essential system for controlling heat dissipation inside the nodule. We keep saline temperature as low as -5 Celsius degrees. This is particularly important when needle tip is adjacent to the danger zone. Here we can see a recent style display of the same parameters. The setup of this display can be modified through a touch screen option. Using this option, you can adapt the size and the position of the functional parameters according to what you need to control at a specific moment during the ablation. And this video shows the options and how we can personalize the parameters on the screen.
I'll now show a recording of the data logger being used on a hands-on session. Again, you can click it, change between impedance and wattage, in between joules and kilocalories. In addition to the color coding bar at the top, there's an audible feature. As the impedance rises, the sound will also change and become faster. If you don't like the sound, you can easily just turn off the sound from the tablet or turn it up if it's not loud enough.
In order to visualize electrode shaft, the ultrasound probe and needle must be perfectly aligned. Ablation starts at the lower portion of nodule, close to the danger zone, when hydrodissection protection of RLN is at a maximum. This part of nodule is ablated first before hydrodissection diminishes, which usually lasts about 15 to 20 minutes and should be repeated if necessary, as I already said. It is customary to use a 7 to 10 millimeters fixed tip needle for standard thyroid ablation. Here we have an example of a 7 millimeters exposed tip. This is 7 millimeters. The needle is made of steel and the tip insulation consists of Teflon. Using shorter active tips allow us to set the generator at a lower power. Here we can see an adjustable tip needle, which could be a suitable alternative for certain types of ablations where RLN protection is more complex. The exposed tip can be adjusted from a minimum of 0.5, which is shown in this figure, to a maximum of 3 centimeters. The main advantage of this type of needle is that the tip length and power setting can be reduced to a minimum when ablating areas near to the danger zone. Conversely, the tip length and power setting can be increased if necessary to efficiently and quickly ablate areas where RLN protection is not a critical factor. So you see the slide, the Teflon sliding backwards and forwards to change the exposed tip. This graph represents the parameters of an illustrative RFA ablation that lasted 70 minutes, performed with 1 centimeter exposed RFA needle tip. Impedance, seen as the green line, averaged between 110 and 130 ohms without any peaks. The interruption of impedance occurs during needle repositioning, here and there. The red line represents temperature. Tissue temperature was measured turning off the saline coolant about 9 times during the procedure. Tissue temperature averaged around 60 degrees, which, as stated before, is optimal in order to obtain tissue ablation. Power orange line, was maintained between 30 and 40 watts. I remind you that this ablation was conducted with 1 centimeter exposed tip. You reduce the power when using 7 millimeters or even 5 millimeters. I have already explained how local anesthesia is administered, and this is the norm for all patients undergoing thyroid ablation, with the extremely rare exception of local anesthetics intolerance. In order to improve patient experience and mitigate pain, sedation and analgesia is almost always advisable. Sedation is classified in 3 levels: minimal, moderate, and deep sedation. We will not consider general anesthesia, which is unwarranted in thyroid RFA. In minimal sedation, the patient responds normally to verbal stimulations and breathes spontaneously. Minimal sedation is obtained with the administration of oral benzodiazepines and can be carried out in a simple ambulatory. In moderate sedation, the patient is more completely sedated but still able to produce vocal sounds upon request. Here, the patient will remember little to nothing about the procedure because of anterograde amnesia, and this is most welcome by patients. Moderate sedation is achieved with a combined administration of intravenous midazolam, fentanyl, and sometimes with a minimum or any propofol infusion. This is a very, very low dose of propofol, 0.1 milligram per kilogram per hour. Here, midazolam and fentanyl are preferred because they both have specific antagonists. Flumazenil for the former, for midazolam, and naloxone for fentanyl. So they both midazolam and fentanyl could be counteracted as necessary, while propofol has no antagonists and must be gradually attenuated. All patients receive paracetamol at the end of the procedure, 1 gram intravenously, to minimize postoperative pain. Deep sedation is obtained with intravenous midazolam together with an infusion of propofol 1 to 2 milligrams per kilogram per hour. In deep sedation with analgesia, patients have depressed consciousness with attenuation of reflexes and only respond to repeated and painful stimulation. Spontaneous breathing is sometimes inadequate and oxygen supplementation may be needed. We can switch patients in an operating room. We can switch patients from moderate to deep sedation by simply starting the propofol infusion, which keep ready to use. Some deep sedation could be useful when ablating large, huge nodules in sectors well away from nervous structures. Now, I would like to explain the evolution of our sedation protocol over time. Initially, we followed a minimal sedation protocol under local anesthesia without the presence of an anesthetist, which allowed us to perform only simple routine ablations. Successively, we moved to an interventional suite where an anesthetist could be available in 20 minutes. So we had to resolve any medical emergencies ourselves, even performing cardiac massage. Successively, in the light of this drawback, we set an operating room with an anesthesiologist in our team. This obviously incurs additional costs, but it is worth it in terms of better patient management and protection against malpractice suits. In the end, we have increasingly adopted the moderate sedation protocol. This option can be combined with flexible fiber optic laryngoscopy, FFL, and vocal cord ultrasound monitoring, which allow an excellent assessment of voice quality during ablation. Moving on now to vocal cord monitoring. Intraoperative nerve monitoring is generally not feasible in thyroid RFA procedures because it requires intubation and general anesthesia. Hence, the gold standard for laryngeal motility assessment is FFL. We use FFL for large and complex thyroid nodule ablations and for professional voice users such as singers, actors, and TV broadcasters. FFL is easily performed by an ENT member of the RFA team and well tolerated by the patient. FFL and vocal sounds produced by the patient allow RLN assessment by visualizing of vocal cord symmetrical movements. Should vocal cord asymmetry appear during RFA, ablation is immediately stopped and hydrodissection with D5W with cold D5W is repeated. This video shows how intraoperative FFL is performed by an ENT member of our team. After moderate sedation, the endoscope is inserted and progressed until the glottic plane is reached. This maneuver is well tolerated by the patient. With FFL monitoring, you can observe calm breathing. After starting RFA, symmetric vocal cord movement during breathing acts demonstrate no RLN irritation. A postoperative FFL is performed on patient immediately after RFA in order to confirm normal vocal cord symmetric adduction during phonation and abduction during breathing. In the video on the left, I am monitoring vocal cord movements through ultrasound while asking the patient to say E. Vocal cord is simultaneously, in this case, we have a combination of US and FFL vocal cord monitoring during RFA. The patient is asked to pronounce E. These are Albanian. we had an Albanian patient. And in the middle video, you can see FFL and vocal cords movements during saying E. And on the right patient, the ultrasound shows the midline movements of vocal cords. As stated before, we are using moderate sedation for these techniques for a thorough assessment of voice quality. This slide shows on the left the location of the vocal cords using the thyroid cartilage notch as an anatomical reference. The glottic plane is about 5 to 11 millimeters below Adam's apple. On the right, we can see the ultrasound image of the vocal cords. So we can play. In the videos, I am asking the patient to pronounce the sound E, and you can see the vocal cords moving symmetrically in the midline. In the two videos of this slide, I want to point out how the ablation near the danger zone is carried out while simultaneously moving vocal cord mobility with ultrasound. In order to monitor vocal cords with ultrasound, the operator must slide the probe from over the nodule to the glottic plane while asking the patient to pronounce E. Perfetto, perfetto. Okay. In conclusion, this slide summarizes the important elements for recurrent laryngeal nerve protection during thyroid RFA. We didn't mention the protection of external branch of the superior laryngeal nerve innervating the cricothyroid muscle, as this presentation was focused on RLN protection. However, the precautions that I described for RLN are valid for EBSLN protection too. Dr. Dhillon will discuss more on this.
That was a great talk, a very comprehensive talk on protection of RLN during RFA. So thank you, Dr. Valcavi. I learned actually quite a bit. I took some notes.
Thank you.
So I'm gonna share my screen. Hopefully everyone can see. So my hope is, and I hope to leave some room for questions. So maybe in the next 10 minutes, just a quick discussion of the talk and sort of what we know from not both operatively, but a laryngology perspective in regards to how we view and monitor the recurrent laryngeal nerve. So really, what's the importance? I'm sure all of us understand that the recurrent laryngeal nerve, its function is very important. Our larynx is a very important organ for voice, prevention of aspiration, and our glottic airway integrity. Dr. Valcavi mentioned this, and I'll bring this up during specifically protection of this branch, but the external branch of the superior laryngeal nerve, it's a very small branch off the vagus, separate than the recurrent laryngeal nerve, but its responsibility really is the cricothyroid function, which is an anterior laryngeal muscle anterior to the thyroid cartilage, which is responsible for pitch, but also projection and intonation. So this is something that while we may not see it always, it's very important, especially when patients have voice complaints after any thyroid or parathyroid surgery, that, you know, if there is not injury to the recurrent nerve, we always have to consider if this is because there might have been an injury to the superior laryngeal. And it's just as important during RFA. So just to briefly go over the two types of laryngeal exams, Dr. Valcavi mentioned the flexible fiber optic laryngoscopy. But this is a bright light halogen view that is very easily obtainable at the bedside as well as in the office, compared to what we as laryngologists use really only in the office because it requires a strobe light. But the video stroboscopy, the difference between the two exams is that this one allows us to see nuances of vocal fold vibration. And sometimes this can be, as I'll mention later on, a little important when patients have voice complaints that can't be explained necessarily by motion abnormality. So this is just a summary of Dr. Valcavi's presentation of how we protect the recurrent laryngeal nerve. And I'm going to break down some of these just to highlight some important things to consider and maybe things in the RFA world that we may want to address as we continue to do this procedure. Dr. Valcavi did a great job about discussing the types of hydrodissection, and I sort of took this large diagram here of the anatomy of the thyroid to kind of highlight the different techniques, mostly to, again, remind all of us that will be doing this or are doing this procedure for our patients, that this is probably the most important way to protect that nerve at the beginning of every procedure. So all of us are very familiar with the superficial hydrodissection that we do for that pericapsular anesthesia, but here highlighted in blue on either side is that posterior hydrodissection, which again protects that danger triangle highlighted in red on either side so that a recurrent laryngeal nerve is not involved or injured during the actual ablation of the nodule within the thyroid. I'm briefly going to mention this because Dr. Valcavi did discuss the importance of the external branch, but if we have a more superiorly placed nodule in the superior pole or maybe closer to the isthmus, we may want to consider a more superior dissection. So sort of turning your needle tip around from the posterior location and angling it more superiorly so that we want to protect that external branch, because that is, as we all know, for those of us that do thyroid surgery, when we're near the superior pole, we want to be very mindful of that external branch. So it's very similar in a superiorly based nodule that we protect it. So that might be an important location to do a hydrodissection. The other important nerve structure in this area, as we are, close to the carotid sheath, is the sympathetic ganglion, which, again, I've never personally seen this, but I know Dr. Valcavi mentioned this to me, but Horner syndrome is also something that if we injure that sympathetic chain, a patient is not going to be very happy, ptosis after a procedure. So again, these are all very important nervous structures aside from the recurrent laryngeal nerve that hydrodissection can protect. We mentioned the temperature of the D5W that we use. I think it's important to consider that we have, all of us that do this, cold D5W in the room when we're doing any procedure so that we can not only use it for hydrodissection, but for rescue. And then repeated versus continuous hydrodissection. I thought this was a very interesting commentary because some of us that are, like myself, still learning this technique, the continuous hydrodissection is something that we should always continue to keep in mind, because I think many of us think that if we start with the hydrodissection and then move on to RFA, that we may not be able to go back to the hydrodissection during the procedure. But I think that today's talk highlighted the importance of knowing that we should continue to do that for protection. Moving on to the RFA technicalities, I want to just highlight one point here about the fixed electrode tip versus the adjustable electrode tip. I know Dr. Valcavi made a great point about using a smaller tip around that recurrent nerve for the low wattage to protect that nerve. I think many of us that are doing this for larger nodules may suggest that we use larger tips, sometimes 1 to 1.5 centimeters. But again, if we're working around that nerve, we want to be very mindful if we don't have the adjustable electroneedle tip to be mindful that we aren't using the 1.5 near the danger triangle. because that can cause injury even if we're not, inadvertently. And so these are important technical things to consider, as well as, the low power setting, that when we are doing this ablation, we're not doing something at 50, 60 watts. So sedation options, this was a great summary as well. I know many of us do this here in the office. I personally do it in the office, which doesn't allow me, unfortunately, to provide deep sedation for my patients. So the most I can give is an anxiolytic, like a benzodiazepine. So while I can allow my patients to be relaxed, most of what I do is under local anesthesia. So I think the location of ablation is really based upon, where we're located, but that obviously influences not just the comfort level of our patients, but our ability to have that perceptual evaluation of the voice during the procedure, which, on top of being mindful of the danger triangle anatomically, we have to be very involved in communicating with our patients, allowing the patient to describe any voice changes, and us also perceptually noting any change in the patient's voice during the procedure. So whatever sedation you do use, and I think all of us agree general anesthesia is not recommended for this, we do want to keep in mind that we're really trying to keep an eye on that perceptual evaluation of the voice as well with our patients. In terms of the actual use of the fiber optic laryngoscopy, when I read Dr. Valcavi's paper, I was actually very impressed, because this is something we do very routinely as laryngologists in thyroplasty. We have a flexible laryngoscopy constantly monitoring the larynx when we're putting in the implant. So it's not uncommon for us to have this ability to do this, and patients' cooperation is pretty well tolerated. So I think that this is a great idea to consider for maybe a challenging case. And I might myself have it more available during the procedure itself rather than just pre and post. But I think one of the things, again, that we should monitor is that we should listen, as I mentioned, but assess as well for pitch, intonation, things that might be more for the EBSLN on top of just the strength or the tone of the voice. So these are things that we can do as well with fiber optic laryngoscopy, as well as the next slide here. I'm just going to jump ahead. The ultrasound. So one of the things that I've learned with using the ultrasound is you have it in your hand, you're constantly doing your RFA, but you also have the ability to move up to the larynx and check the laryngeal motion grossly. So, things to consider is making sure that before you're checking that laryngeal ultrasound pre-procedurally, you can see your vocal cords, because some of the considerations with the laryngeal ultrasound may be calcification of the cartilage, the body habitus of the patient. And so these are things that if you can't detect motion pre-procedurally, you're not going to be able to do this well during the procedure. So make sure you have a really nice laryngeal ultrasound before actually implementing it during the procedure. And then other things to consider when the patient is during the procedure that may not just be a voice change, or cough, a tickle, or discomfort in the throat. These are things that if patient's describing those things during the procedure, you want to be able to check the larynx to make sure that it's not a recurrent nerve injury. And so these are other just nuances that you may want to use the ultrasound for. So I kind of jumped ahead, but that was my last slide. But I think that in general, the use of both the fiber optic laryngoscopy and the ultrasound are both really important tools that we already know we can use on top of all the technical things to protect the nerve. I think things to consider, obviously, we want to have a pre-procedural exam of the larynx, a post-procedural exam of the larynx, and any sort of complaint that can't be described by the fiber optic laryngoscopy post-procedurally, the patient should be referred to either a laryngologist, ENT, speech language pathologist, and have a video stroboscopy just to make sure we're not missing anything. Thank you.
Thank you.
Terrific. Thank you both. And again, I want to encourage all of our listeners, if they do have questions on this important topic, to send those in, and let's see if we can't get those answered. it seems to me that that you're behind the eight ball if you are looking for listening for a voice change or looking for a motion abnormality to know that you have caused at least an injury of some sort to the recurrent laryngeal nerve. How comfortable are you that with kind of this post-injury assessment? Obviously, it tells you to stop the procedure, to continue to do additional hydrodissection, but it seems to me that you've already caused some thermal injury at that point. Is that not a realistic way to think about this? Either Dr. Dhillon or Dr. Valcavi?
Yeah, maybe we are behind the laryngeal nerve, but we are. This is all we can do. We can check as many times as we want, volume, as well as pitch and voice of the patient, and I cannot think of anything else we could do more than that.
Yeah, I think some of the case report and the case studies have shown that most nerves, even if they don't recover intraprocedurally, it's usually a transient or temporary paralysis. The rate of permanent paralysis past 6 months for the patients that have been described are very, very rare compared to surgically. So I think that, the thermal injury may be a little different than what we experience as thermal injury or cautery injury intraoperatively when there's injury to the nerve. It's not actually necessarily a direct injury, but more of like within the zone. And so that, everyone always recommends a rescue and that repeated hydrodissection. But in terms of the overall rates of permanent paralysis, they're still very much lower than surgically from what I've read.
So thank you. It seems to me, and I understand the value added of from a patient and a logistical perspective of not using general anesthesia. I've become a tremendous fan of the use of continuous intraoperative neuromonitoring. And while there are personnel challenges, the incredible value and the subtlety seem to be certainly something that could be of tremendous value in this setting. Have you given that much thought here? Maybe Dr. Dhillon, obviously you have experience more from a surgical perspective.
I mean, I think that the comment about the fact that we're behind the eight ball is the same in surgery as well. I mean, at least with the intermittent nerve monitoring. I personally haven't had too much experience with continuous, but I know it's much better real-time monitoring. I think it would be very interesting to see if we could adapt a continuous nerve monitor to our RFA electrode. Have some sort of ability to do something where we can have real-time adjustments that really don't, we're not kind of once that effect is made, we have to somehow reverse it. But I mean, that's just an idea. So I definitely agree with the theory. I do feel, however, that a lot of what Dr. Valcavi described with the technical, the technical things that we need to consider during RFA are very much protective. And if we implement them, then, our rates should be lower in terms of hydrodissection, power, impedance spikes, electrode tip. And again, I think because we're still learning all of that, I think that those things have to be implemented, which may be a little bit different than the operative case. But I think that overall, from, like I said, what we know, the rates are still much lower for RLN injury. And that's actually, I think why patients sometimes seek RFA, because some of them are professional voice users with these nodules, or, singers, or very concerned about that risk in operatively and do want to seek the alternative to see if there is actually less risk. So, I mean, I think that would be to have monitoring ability during RFA would be a great way to maybe prove that to our patients, if we could.
Do you have, I'm sorry, go ahead, Roberto.
We checked with our provider, which is based in Germany, whether there could be the possibility, that could be an idea of picking up the nerve signal by ceramic electrodes. Because we are scared of the voltaic arc. This is not considered by Beck. I spoke with him, and he uses steel needles for continuing hydrodissection, but still I don't like the idea of having an electric current with another the possibility of a voltaic arc, a short circuit, we call it. So we discussed with our provider, our European provider for intraoperative nerve monitoring. This brand makes the intraoperative widely used in Europe, intraoperative tubes, and we discussed the possibility of picking up the signal of the recurrent laryngeal nerve, inserting externally an electrode, a very thin electrode, ceramic electrode. So
Great.
This is an idea. This is an idea.
So do either of you have any, I asked this question several weeks ago on this topic of actually recording or measuring temperature within the hydrodissection plane. It seems to me that would be an easy thing to get a better handle on how much heat you're actually generating in the perithyroidal area. Do you have any experience or any thoughts on that?
No, I don't. You should insert another thermocouple, another needle with for measuring. So one needle for hydrodissection, one needle for thermal ablation, and one more needle. It seems to me too complicated for measuring the hydrodissection temperature. Maybe measuring the tip needle temperature many times while we are close to the danger triangle, while we are adjacent to the danger triangle, may give us an idea. There are some generators which are very fast, which provides the internal temperature of the tip simply by stopping the coolant, the pump, which the peristaltic pump, which pushes the coolant inside the needle. Simply stop the pump, and you can measure in 15 seconds the temperature inside the tissue. This can give you an idea of how high is the temperature in the tissue.
Okay, thank you. My last question, we're up against the 9 o'clock hour. Is there any, so if you, it sounds like you're incredibly comfortable with the value added of hydrodissection, and that seems to be the standard of care. Is there any nodule position at this point that you would say this is not a candidate, aside from histology, but just based on geography within the thyroid?
Yeah.
Not.
Well, for instance, an isthmic nodule could not be a candidate for hydrodissection. because you don't have in the isthmus, there are no nerves, no nervous structures.
Vaninder, how about you? Is there any nodule position that you say this is too dangerous?
Yeah, I think from the fact that I'm still learning this technique, I'm more adverse to doing more posteriorly based nodules, those along the TE groove still, or near the, like, really adjacent to the trachea on the right. I'm a little bit more apprehensive about doing those just because, again, you know, the risk of injury is higher, but I think, yeah, the in general, the more anterior, and maybe even superior, sorry, I should mention that too, based upon the EBSLN, but that's still yet to be determined.
If
Great.
I could shortly comment, you can promise a 90%, not a 100% ablation to the patient. So the number one issue is saving voice. And for a benign nodule, if you ablate 90% of it, is enough.
That's true.
Great. Terrific. Thank you all. Thank you both very much. Thank you everybody for listening. This was highly informative, and everybody welcome you back next week for next week's presentation. Thank you, Dr. Dhillon and Dr. Valcavi. Much appreciated.
Thank you,
Thank
Dr.
you.
Lincoln. Thank you.
Thank you.
Bye-bye.